Welcome back to the Deep Dive. So glad you could join us. Today we're tackling something really prevalent. You see it constantly in the ER, but it's one of those sneaky challenges. Acetaminophen overdose. It can look so benign at first.
Yeah.
Right. But then, boom, it unleashes this just devastating damage, and fast. So our mission today, equip you, our awesome ER nurses, especially those in the thick of it at a level 1 trauma center, with the critical, the nuanced knowledge you need for timely management, getting that antidote protocol exactly right. This isn't just book learning. This is about your actual patients, the ones walking in.
Okay.
Your actions. They can literally change everything. We actually have, believe it or not, a literal antidote for this one. Pretty amazing.
It really is. And you hit on something key there, that deceptive initial presentation. That's what makes AP-PAL acetaminophen so dangerous. They often look fine, maybe a bit quiet, tired. But inside, their liver's getting hammered. Silently. And that gap between how they look and what's actually happening, it creates this this race against the clock, a really tight race. So getting the protocol right isn't just important, it's everything. The window is narrow, the stakes are incredibly high, every little detail counts.
Definitely. Okay, so let's kick this off with a scene. You've probably seen this 100 times, right? Busy shift. Teenager comes in, maybe after a fight with parents, looking kind of sullen, scrolling on their phone, and they might just casually say, yeah, I took a handful of Tylenol. For us, that's not casual. That's like alarms going off. Acetaminophen overdose. It's super common, like we said, and just so sneaky. First 12, maybe even 24 hours, they can seem totally fine, alert, talking, maybe a little drowsy. But internally, what's actually going on, their liver is silently getting torched. Like serious biochemical assault happening under the radar. We're talking major cell damage unfolding, but no obvious signs yet. So the big question is, how do we jump in? How do we stop this quiet killer attacking this vital organ? What's our weapon?
And that weapon is N-acetylcysteine. NAC, that's what we all call it, right? It's genuinely our secret weapon here.
Yeah.
A literal antidote. It can just stop the damage cold.
Wow.
This isn't just, supportive stuff like fluids. It's a direct hit at the cellular level, specifically stopping that liver toxicity. And to really get why NSC works, why it's so genius, you kind of need to understand the toxicity itself. See, normally when you take Tylenol, your liver handles it fine, metabolizes it into harmless stuff. But a tiny bit, maybe like 5%, goes down a different path using this enzyme, CYP2E1. And that path creates this really nasty toxic thing called NAPQI. NAPQI. Usually no big deal. Our body has this natural antioxidant, glutathione, that zaps NAPQI right away, neutralizes it, gone, safe.
Okay, so glutathione is the good guy.
Totally. But in an overdose, there's just too much acetaminophen. The normal pathways get overwhelmed, so way more gets pushed down that toxic NAPQI pathway. You get tons of NAPQI being made, and crucially, the overdose uses up all the glutathione super fast. It's depleted.
Oh, so the good guy runs out.
Exactly. And with no glutathione left, NAPQI just runs wild. It starts attacking liver cells, binding to them, destroying them, causes massive cell death, necrosis. That's what leads to liver failure. NAC, our antidote, swoops in. It gives the liver the building blocks, mainly cysteine, that it desperately needs to make more glutathione.
Ah, so we're reloading the defense system.
Precisely. We're rapidly rearming the liver so it can fight off that NAPQI before the damage is permanent. It's like this desperate cellular firefight. And if you think about it, in the ER world, this is one of the very, very few times we have a true specific antidote for a poison.
Yeah, that's a really good point.
Most of the time we're managing symptoms, trying to help the body clear stuff out slowly. Here, we can stop the injury directly, which makes getting that NAC protocol exactly right, understanding every step, absolutely critical. It's not optional. It's the difference between full recovery and, needing a transplant. Or worse, getting the timing and dosing right is everything. And, it helps to think about the phases you might see as a nurse. Phase 1, the first 24 hours, that's often that sneaky, maybe no symptoms phase, or just mild stuff, nausea, maybe some sweating, liver's getting hit, but you don't see it yet.
The quiet phase?
Right. Then phase 2, maybe 24 to 72 hours, now the liver injury shows up, maybe some belly pain, upper right side, and the labs, AST, ALT, they start climbing. Bilirubin goes up, INR gets longer, liver struggling.
Okay, now we're seeing the damage.
Yep. Phase 3, 72 to 96 hours. That's peak toxicity. This is where you can see full-blown liver failure, jaundice, confusion, bleeding problems, low sugar, kidney failure even. Transplant becomes urgent here.
That's the really critical point.
Absolutely. And then phase 4, after 96 hours. Either recovery, hopefully, or it progresses to multi-organ failure and death. If they make it, recovery is usually complete if we treated it right. Also, keep in mind, some folks are at higher risk. chronic drinkers, malnourished people, anyone on certain meds like seizure drugs or TB meds, they can get hurt by lower doses. Got to be extra vigilant with them.
That breakdown, the mechanism, the phases, it really hammers home why we can't afford to wait around, why speed is just crucial. And for us nurses, that urgency kicks in the second they walk in the door, right?
Yeah.
During that initial assessment, this is where you are just indispensable, gathering that info. And the absolute first, most vital question you have to ask, and you got to dig sometimes, get specific, is when exactly did you take the pills? Not just when did you take them, but exactly when. It's the key. It dictates the whole plan. You need specifics, whether one single handful all at once, like grab the bottle, pour it some out, swallow them down, that's acute. Or have they been taking extra for a headache for days, a few too many every few hours? That's staggered. Or chronic. That single detail, it changes the entire game. It's not minor, it's fundamental.
Absolutely spot on. That timeline is the bedrock. Everything else builds on that. So for that single acute overdose, the one handful scenario, everything pivots around one specific time. 4 hours post-ingestion.
4 hours.
That's the earliest you can reliably draw that first acetaminophen level, the APP level. And you need to know why 4 hours. It's about how the drug moves through the body, pharmacokinetics. It needs time to get absorbed from the gut into the blood, right, to hit its peak level. Usually peaks maybe 1 to 2 hours, but it varies. Food in the stomach, how fast the gut's moving. So if you draw it at, say, 2 hours, the drug might still be absorbed.
So the level might look lower than it actually will be later.
Exactly. Falsely low. And that's where the danger comes in, which leads to a huge warning. Do not let anyone, a new resident, whoever draw that first level at 2 hours, seriously.
We do it.
It's worse than useless. It's dangerous. You see a low level, you think, oh, okay, they're good. Maybe you discharge them, maybe you delay treatment, and you completely miss that critical window.
Oh, man.
I remember this case. A new grad drew it early, level was low, patient felt okay, almost got sent home. Took a senior nurse stepping in, remembering a near miss years ago, insisting on a 4-hour level. Sky high. Toxic. That nurse's vigilance, knowing the why of the 4-hour rule, saved that kid from needing a transplant. It's a stark reminder these rules exist for a reason. So, gotta ask yourself, right? If someone does draw early, how does that screw up your workflow, your assessment, patient safety? It's not just a waste of lab resources, it's a dangerous false reassurance. Your job is to make sure that 4-hour mark is sacred, non-negotiable. Now, what if the time is fuzzy, like they really don't know when they took it?
Yeah, what do
you still draw a level right away, but you can't plug it into the nomogram reliably. You have to look at the whole picture. Symptoms, baseline liver enzymes, AST, ALT, any detectable level plus rising enzymes. You might need to treat empirically based on that, not just wait for a specific time point.
Makes sense. Clinical picture.
And one more thing, extended release Tylenol. Tylenol ER.
Right, the long-acting stuff.
Yep. That release is slower, so a 4-hour level might miss the peak. For those, you often need a second level, maybe 4 to 6 hours after the first, just to be sure. Shows again why getting that initial history, what kind they took, when, is so crucial.
Okay, so you nailed down the time, you waited patiently, precisely, got that blood draw at 4 hours or later, lab calls back with the APA level. Now what? Now you pull out the magic 8-ball of toxicology, or, the Rumac-Matthew nomogram. Seriously, every ER has one, laminated on a wall, on a computer, baked into the EMR. It's the rule book for these single acute ingestions, your guide. Using it seems simple, but again, precision matters. You find the time post-ingestion, your accurate time, 4 hours plus on the bottom axis. Then you find the APIP level from the lab on the side axis, and you see where those 2 points meet, like plotting coordinates, right? If your patient's dot lands above that solid treatment line, that's it. They get NAC. End of story. No debate.
Right.
That line is based on tons of data. It's validated. It gives you that clear go signal to start treatment and protect that liver. It gives you confidence.
That go signal is clear, yes. But, and this is maybe the most critical caveat, the nomogram is only, and I mean only, for a single acute ingestion of immediate release acetaminophen where the time is known.
Okay, say that again. Single acute immediate release known time.
Exactly. That's it. If any of those aren't true, the nomogram is garbage for decision-making. Patient took pills over hours, staggered. Throw out the nomogram. Patient's been taking too much for days. Chronic overdose. Throw out the nomogram. Time of ingestion totally unknown. Throw out the nomogram. Extended release pills. Throw out the nomogram.
That's really specific.
Extremely specific. It relies on that predictable drug curve from one single hit. Staggered doses, chronic use, extended release. They totally mess up that curve. The nomogram just doesn't work then. Using it is dangerous.
So what do you do in those cases? The staggered, the chronic, The unknown time.
Then the decision shifts. It's not about one point on a graph anymore.
Yeah.
You look at their liver enzymes, AST and ALT. If the enzymes are up and you can detect any acetaminophen level in their blood, even a low one, they need NAC.
Ah, okay. So elevated enzymes plus any level equals treat.
That's the rule for those situations. Plus, you look at the clinical picture, obviously. Jaundice, confusion, bleeding, all red flags. Seriously, don't be the person who misuses the nomogram in the wrong situation and misses a liver failure starting. The consequences are just devastating.
Yeah.
And it's your responsibility to get that judgment call right. It really shows, knowing the limits of your tools. That's as vital as knowing how to use them. Especially in toxis, blindly using a tool where it doesn't fit. Bad news. Clinical judgment, understanding the why, that's key. And just a side note, some nomograms have a second, lower line for high-risk patients, alcoholics, malnourished folks. They might need treatment at lower levels. Got to be aware of that, too.
Right. Those nuances are so important. Okay. So you've done the work. The nomogram said yes, or your clinical judgment based on enzymes and levels said yes. Doc says, hang the NAC. Now, if you've been around, you know NAC by its nickname, right? Nasty NAC. And let's be real. It can be a pain to manage sometimes. It has that distinct sulfur smell patients hate. And the whole multi-bag long infusion thing, it feels like a 3-bag circus.
You definitely can.
So we usually use the 21-hour IV protocol, 3 different bags, 3 different rates. Pharmacy's usually great. They mix it perfectly, send it up. But you, the nurse at the bedside, you're the last stop, hanging it, watching it, making sure it goes in right. Knowing that protocol inside and out is crucial. Lets you catch errors right. But what about the real-world stuff? What if you have awful IV access or a super agitated patient yanking at lines? How do experienced nurses handle that and keep this critical drip running?
Yeah, great questions. That's where your skill really comes in. Let's break down that 3-bag circus because, like you said, precision is key. Standard 21-hour IV protocol, bag 1, loading dose, that's 150 milligrams per kilogram, goes in fast, usually over just 1 hour, gets the levels up quick. This is often where you see that reaction we'll talk about.
Okay, fast and heavy first.
Yep. Bag 2. Second dose, that's 50 milligrams per kilogram, slower, runs over 4 hours. Bag 3, final dose, the long haul. 100 milligrams per kilogram runs over 16 hours, keeps the levels steady.
16 hours.
Yeah, it's a commitment. Now, all of this, every single calculation hangs on one thing: accurate, patient, weight.
Cannot stress that enough, right?
Cannot stress it enough. Do, not guess. Don't eyeball it. Get an actual weight. This whole thing is weight-based. Get the weight wrong, you're either underdosing, not protecting the liver enough, or overdosing, risking side effects, fluid overload. Just don't mess it up.
Find that working scale, even if you have to track down Sarah from PEDS because she hit it again.
Exactly. Whatever it takes. That accurate weight is the foundation. It's what makes this different from just giving a standard adult dose of something else. Requires that bedside diligence. And addressing your other points, yeah, challenges are real. That fluid volume, it's a lot, several liters. Think about your heart failure patients, kidney patients. You got to watch fluid status closely. INOs, lung sounds, vitals. Sometimes the docs might use concentrated NAC, but IV is still preferred for speed.
And the access issues. Agitated patients.
Big challenge for a 21-hour drip. If peripheral IVs keep failing, maybe a central line, though that has risks, midline or PICC if they're admitted. Otherwise, get creative with securing it. Stat locks, co-bin, arm boards. And manage the agitation, calm talk, distraction, maybe sedation if needed and ordered. Also, remember other side effects besides the reaction. Nausea, vomiting, belly pain. Have antiemetics ready.
Does it interact with other overdose drugs like benzos or opioids?
Not really in a way that changes NSC's effectiveness directly, but other drugs definitely complicate the overall picture, mask symptoms, so your assessment has to be even sharper. Every patient's different.
Okay, so you got the weight, lines are good, bags are hanging, pump is running. First bag, the loading dose is going in fast. And then, bam, maybe 15 minutes in, your patient turns beet red, starts itching like crazy, breaks out in hives everywhere, and the first time you see that, oh man, it will freak you out. Your gut just screamed, anaphylaxis.
Totally.
You're thinking epi, airway kit, the whole 9 yards, total panic mode, right? It looks just like it.
It does look like it. And that's where you take a breath, use your knowledge, and stay cool. Because, and this is so important, it is not anaphylaxis.
Not anaphylaxis.
It's an anaphylactoid reaction, different mechanism. True anaphylaxis is that IgE antibody thing, the immune system attacking, that needs epi. This reaction with NSC, it's usually caused by the fast infusion rate of that first bag. It makes mast cells directly release histamine, but it's not that specific immune attack.
Ah, so it's the speed causing it, not an allergy.
Mostly, yes. Think of it like a chemical irritation causing histamine release rather than a true allergy. It happens all the time with NSC, especially with that fast load. Flushing, itching, hives, sometimes wheezing or low BP, but it's managed differently. So your first move is not epi. Here's the calm step by step. 1. Pause the drip. Stop the infusion right away. Stops the
Thanks,
trigger.
a pump.
2. Give IV Benadryl, diphenhydramine. That helps block the histamine causing the rash and itch. 3. Let things calm down, usually 15-30 minutes. Watch them closely. Vitals stable, breathing okay, color coming back, itching less.
Wait it out.
4. Once they're better, restart the infusion. But key change, run that first bag, or what's left of it, over 2 hours instead of 1.
Ah, slow it down.
Slow it way down. That slower rate usually prevents the reaction from happening again. If it does happen again, slow it even more. Talk to the doc, maybe toxicology. Handling this smoothly without hitting the panic button. That's the mark of a pro. Shows you know your stuff. You totally got this. And, this really makes you think. Understanding the mechanism, the why, behind anaphylactoid versus anaphylaxis. How does that change how you look at all drug reactions in the ER?
Yeah, good point. Knowing the why lets you react correctly, not just reflexively.
Exactly. More precise, more confident, safer care. Turns panic into a managed event.
That distinction is huge. Okay, so let's bring it all together. The big picture, the game plan for every single time you encounter this. It sounds simple, but it needs that precision, that vigilance we keep talking about. Step 1, get the time right. Crucial first step. Step 2, draw the level at 4 hours or later. No cheating early. Step 3, use the nomogram right. Know when it applies, and more importantly, when it doesn't. And step 4, when that NAC reaction hits, don't freak out. Pause Benadryl, wait, restart slower, manage it. Because, and this is the payoff, if we, the whole team, get that NAC started within that golden window, ideally within 8 hours of the overdose, we can almost guarantee we save their liver.
That's huge.
That's not just a good outcome, that's life-changing.
And the flip side is just as stark. It really underscores the weight of what you do. Miss that 8-hour window. Delay treatment. You might be moving from managing liver injury to calling the transplant team because the damage is done. Irreversible necrosis.
Why hours makes that much difference?
It can be the difference between walking out healthy and needing a new organ. Or worse, a few hours, a misstep. It changes their entire life. Which brings us back to why NAC is so special. It's one of those rare times we have a true direct antidote.
Right.
We're not just supporting them, we are actively stopping the damage cascade, preventing catastrophe in real time. Miss the window, and it's not just liver failure. It's bleeding, confusion from toxins, kidney failure, electrolyte chaos. Huge downstream effects. So because we have this powerful tool, this direct ability to change a life, the final word has to be your diligence matters profoundly. Precision, timing, they aren't just nice ideas, they're everything. Don't mess it up. Hashtag tag out, track and pay trust.
So yeah, what's the bottom line here for you? On the front lines in the ER. It means you are right there, holding this unique, powerful opportunity to directly reverse a potentially lethal situation with knowledge, with precision. You're not just pushing meds, you're running a complex, life-saving strategy. It's a huge testament to your skill, your focus, your critical thinking. So here's something to think about, beyond just the protocol steps that we went over. What else can you do on your shift? What systems, what habits can you put in place to make sure that 4-hour mark gets hit, that accurate wait always gets documented? How do you guarantee these things don't slip through the cracks, even when it's absolutely chaotic, phones ringing, alarms going off, juggling 5 other critical patients? How do you protect that life-saving window for everyone who comes through those doors needing it?
Yeah, and stepping back even further, it really speaks to the core of emergency nursing, doesn't it? Your meticulous assessment, your adherence to protocol. It's not just checking boxes, it's being that critical safety net, preventing disaster. You're the one who notices the small thing that's off, who double-checks the dose, who calmly manages the reaction because you understand the why. That commitment to detail, even finding the working scale or teaching the new person the 4-hour rule again, that's what makes the difference. That's being the sign of a pro in every single thing you do, making sure that for every single acetaminophen overdose, that antidote gets there exactly when and how it needs to, protecting their future.